How loud I talk. So first off, thanks everybody for being here. I know that we're in our last day of the conference. You've heard a lot of information, a lot of great information, and that does a couple things. For one, it sets you up that you already have a good understanding of narcolepsy and everything that comes with it. It also makes it that you already have probably heard many of the things I'm going to mention today. So sometimes that can put me at a loss because I'm telling you things you know, but also hopefully it just helps integrate everything and really help you get a good understanding of what I'm trying to talk about. And what I'm going to do is really try to talk about both chronic pain and narcolepsy and really bridge the two. 50 minutes isn't enough to give either justice, but we're going to do our best. And so what I'm going to focus on are a few things, pardon the spacing, but first is I just want to talk about what acute and chronic pain are. There's a lot of different ways we can experience pain, and to really understand what we're talking about, we have to go through some definitions. And even if we just leave with that you know more about chronic pain, it's a great thing to know about. Either someone is in yourselves or somebody you know or care about likely has chronic pain or is dealing with it. The other thing is just the understanding between sleep and narcolepsy. This is some things that have been reviewed already. I know our keynote touched some of this. And then also the strategies that help with both of them. And I'm going to try to spend a little bit more time on this. Some of the strategies you've heard before. Maybe some are new, and we're going from limited work at the time. It's still a very new and developing field. Well, we're not really responsive like we need to be. All right, that's fine. Maybe it's not. Okay. All right, we'll just go with it. Well, that's not good. All right, so we're going to get somebody from, we're running out of internet. That's not good at all. All right, we're going to wing it for a second. So just to start off, chronic pain is a very prevalent problem that we have. It's something that recent estimates are saying over 30 million or really, we're back. Reload the page. Okay, thank you. All right. That was scary for a second. All right. All right. It's much better with pictures, I promise. Here we go. Okay. That's what I wanted to show you. So a huge problem, and this is one of the estimates, really when we're thinking about chronic pain, between 12 and 38% of the population is what we're looking at. And chronic pain, we're going to go over in a second the definition of, but it's pain that lasts and lasts and lasts. And when I think of chronic pain, it's pain that's lasted over 3 months and just sticks around. We're going to compare that to acute pain, but to help me with this, I'll have some video for you. Narcolepsy, you already know what that is. And this, of course, the points I want to focus on are just the issues with sleep, the hallucinations that come with it, as well as just symptoms in general. So I'm not going to spend a lot of time on this. You've heard about it all weekend. Here's what I wanted to get you to. This is one of my favorite videos. It's from a group in Australia. And what this focuses on is just an explanation of chronic pain. And again, chronic pain, we're talking about pain that's outlasted any acute problem or illness or condition. So let me just start you with this video, and then we'll all have a good basis to work from. So go ahead.
Everyone agrees that pain is a universal human experience. We now know that pain is 100% of the time produced by the brain. This includes all pain, no matter how it feels, sharp, dull, strong, or mild, and no matter how long you've had it. You might have had it for a few weeks or months. This is called acute pain, and it's common with tissue damage, say from a back injury or ankle sprain. And generally, you'll be encouraged to stay active and gradually get back to doing all your normal things, including work. Or you might have had it for 3 months or more, and this pain is generally called persistent or chronic, because in this type of pain, tissue damage is not the main issue. What's less clear, though, is when you're told you have chronic pain, is knowing what's best to do about it. Well, in Australia, chronic pain is a really big problem. In fact, 1 in 5 people have it. Having a brain that keeps on producing pain, even after the body tissues are restored and out of danger, is no fun. Some people say it still feels like they must have something wrong. But that's just it. Once anything dangerous is ruled out, health professionals can explain that most things in the body are healed, as well as they can be by by 3 to 6 months. So ongoing pain being produced by the brain is less about the structural changes in the body and more about the sensitivity of the nervous system. In other words, it's more complex. So to try and figure out what's going on, you need to retrain the brain and nervous system. To do this, it's helpful to look at all the things that affect the nervous system and maybe contributing to your individual pain experience. What can help is to look at persistent pain from a broad perspective, and by using a structured approach and a plan, it's less likely that anything important will be missed. Let's start with the medical side. Firstly, taking medication can help, but only to a limited extent. It is the more active approaches that are necessary to retrain the brain. So using medications to get going is okay, and then mostly they can be tapered and ceased. Some people also think surgery might be the answer, but when it comes to a complex problem like chronic pain, surgery may not be helpful. So if you're thinking of surgery, it's best to get a second opinion, and remember to consider all the things. Next, it is helpful to consider how your thoughts and emotions are affecting your nervous system. Pain really impacts on people's lives, and this can have a big effect on your mood and stress levels. All those thoughts and beliefs are brain impulses too, but you can learn ways to reduce stress and wind down the nervous system. This helps with emotional well-being and can reduce pain as well. The third area to consider is the role of diet and lifestyle. Now, it turns out that our modern lifestyle might not be so good for us. In fact, what we eat and how we live may really be contributing to a sensitized nervous system. Looking at all the things like smoking, nutrition, alcohol, and activity levels, and seeing if there are any issues is a good beginning, and these things can go on your plan. Then there's often enormous value in exploring the deeper meaning of pain and the surrounding personal story. By stepping back and looking at all the things that were happening around the time the pain developed, many people with pain can make useful links between a worrying period of life and a worsening pain picture. For many, recognizing deeper emotions can be part of the healing process. Last, but by no means least, is physical activity and function. From the brain's perspective, getting moving at comfortable levels without fear and where the brain does not protect by pain is best, and you'll gradually restore your body's tissues. So, to sum up pain, it comes from the brain and it can be retrained, and when looked at from a whole person or broad perspective, gives you a lot of opportunities to begin. So, get a helping hand if you need it, set a goal, and begin.
So you're all pros in chronic pain now. Good job. No, I really like this video because it really gives a nice explanation of what chronic pain is and how it might work in someone. And I should also mention, I didn't at the very beginning, I'm a pediatric psychologist by trade. Pain is my specialization. And because it is such a complex issue, that's part of why I'm involved. It's the multidisciplinary approach. But what I want to focus on up here is just the difference between acute and chronic pain. Acute, oh, yes. Absolutely.
Is there anything in this modern age that shows anything different about a brain with chronic pain and a brain without, so that there's some grabbable, feelable difference the way the hyperfrequent thing is in narcolepsy that you can point to rather than the psychological or something vague like?
Yes, there is, and I'll touch on that too with the hypercretin and how that's impacting it. But overall, I think one of the biggest issues with chronic pain is that it's an invisible illness. It's an invisible problem, and I think one of the most unfortunate and invalidating things that happen is sometimes as physicians, we tell patients it's all in your head or it's purely psychological, and that's just purely incorrect. That's not how it works at all. Pain actually is defined as both an emotional and a physical experience. You can't separate the two. It doesn't matter if you hit your hand with a hammer or you're experiencing fibromyalgia pain for half your lifetime. It's still both parts. And so getting back to this with acute pain, this is what's happening when you hit your hand with a hammer or you break your ankle. It's a helpful pain. We usually know where it's from. It's protective. It does its job well. We know what to do for it too. We know how to treat it. Chronic pain, that's where it gets a little bit more dicey. With chronic pain, and you just heard on this, there's a lot of things that kind of lead to it and that can be impacting it. The biggest issue is we don't always know why it comes about. For some people, it happens after an illness or after an injury, an accident, absolutely. And for some people, they heal properly, and other people, it just lingers and lingers even after the tissue is healed. And that's when we start talking about chronic pain. Also want to separate this from chronic medical conditions with acute pain flares, because there's also that too. But even people with things like arthritis, sickle cell, conditions like that, where there are flares, they can have chronic pain on top of that. Makes for quite the mess. But again, not always correlated with damage. The big thing I think down here too is how it can be related to mood. With acute pain, usually we see mood improves and the injury improves, but with chronic pain, just the impact it has on life, it can keep on going and affect us in a lot of different ways. The alarm system too, this is the way I explain it to kids, and I think it's helpful for adults too when we're talking about chronic pain. I think of chronic pain like a faulty car alarm. With a car alarm, you've probably heard one before go off. They're great. They protect your car if somebody's breaking in or something like that. But hopefully the last time you heard a car alarm go off, that wasn't the case. Rather, somebody walked by and brushed it, their music was too loud, something like that. What happened is the car did its job too well. It had these sensitive mechanisms inside of it, which caused the sound to go off. And what you get is a sound that's very loud, very annoying, and also very real. It just doesn't tell you that anything dangerous is happening. Chronic pain works very much in the same way, except we're talking about your nerves. You have something that's very loud, very annoying, and also very real. However, it doesn't tell you that danger is happening. Again, separate from acute pain. So I'm not going to get too far into what's happening within the brain. This is a little bit beyond the scope. But really, with chronic pain, we're noticing that it's not something that's psychological. It's not something that's in your head. There's actual changes in your nervous system and how it's working. A couple of those being that the parts of your brain that perceive pain, that send pain signals, they start working too hard, too well. And then also some of the descending pathways that block pain, those stop working the way they should. So there's a couple different ways that pain isn't working. And again, this heightened sensitivity, we usually talk about central sensitization, that your nerve systems become much too sensitized, so we're experiencing more pain than we should. There's a couple different phenomena that happen with this. One I'll talk about in a little bit, allodynia, where just light touch can hurt really badly. And then another one, hyperalgesia, where sometimes a pain that would be a little bit painful to anyone is a massive pain. And again, the system's working way too well for those. So let's breach it to sleep, because again, we're at a narcolepsy conference. We want to talk about this. Pain and sleep are very much related. We have a lot of research on this. What we find typically is that when you have a bad night of sleep, you have a lower pain threshold. You're going to experience more pain along with a whole host of other factors. How well you're doing cognitively, how well you're able to focus, things you probably already know or have experienced yourself. On top of that, we find that people with chronic pain, they have a lot of sleep problems. Sometimes that's because they're not comfortable, they can't go to sleep, or maybe they're waking in the night. But that's not really what we find all the time, and it's not a bidirectional relationship. We find that a bad night of sleep will definitely affect pain, but having pain won't always affect sleep. So we find that not the first one. Now, to the hypocretin. So we know that hypocretin does have an impact on pain. And what we find is if we inject rats with hypocretin, they have less pain signals. There's a couple studies on this. And we also know that with narcolepsy, this is a problem too, that especially the narcolepsy plus cataplexy, the narcolepsy 1, there's decreased hypocretin, which would make us assume that therefore we're going to be able to have lower pain thresholds, experience more pain. And along with that, there's a lot of frequent comorbidities that are seen that kind of go to this same concept. With narcolepsy, you're going to have increased rates of sleep apnea. Bad sleep again, less pain threshold. Anxiety affects that central nervous system. It affects pain sensitivity. And then we also see that frequently we're seeing people with fibromyalgia, with migraines, headaches, very common in narcolepsy. So there's this link there that hasn't been well studied. There's only a handful of studies on it, but we know those are there. Some of the research that we have, and again, this is limited, says that amongst people with narcolepsy, you're going to have higher rates in people with narcolepsy 1 than narcolepsy 2. And really saying that even beyond the general population, there's just a higher incidence rate, which initially led to us believe that, well, you're even at higher risk when you have narcolepsy 1. And of course, this is related to a whole host of other things, mood, quality of life, that again impact pain. Whole complicated system, but a lot of it that you're experiencing. Ooh. However, a couple recent studies came out that in a way contradicted this. One of them finding that amongst controls and people with both types of narcolepsy, there's this increased incidence, 85, 76% of the people in this study. It wasn't a huge study, I think it was around 100 people. But again, much higher than the general population, and then also not that much of a difference between the two types of narcolepsy. And then that's found in some other studies too that show that the incidence rates of some of the conditions we're thinking of. With musculoskeletal and connective tissue, we're talking fibromyalgia, Ehlers-Danlos, conditions like that, and then of course migraines, headaches. So a little bit confusing. The research is still sort of new, and it's, well, right now I think the takeaway is that if you have narcolepsy, there's a higher chance you might experience chronic pain. On top of this general population, we have about 1 in 3, 1 in 4 people in America with that. So what do we do? That's really what we came for. What do we do with this? You know if you have chronic pain, you know if you have narcolepsy, and that's what I want to focus on. And there's only one research paper I'm really going to focus on that addresses my part of this. But what most of the research has said is that we want to have more attention to this. We need more treatment. We need to start thinking about it more, and then really do stuff for quality of life. And that's an area that I'm going to focus on, is just how do we make people more functional? How do we get them back to the things you love, the things you care about? So, I'm a psychologist. Cognitive behavioral therapy is one of the things I do. I love. It's a gold standard type of treatment. It's something we use often for all kinds of conditions. If you don't know about it, cognitive means your mind, your thoughts. Behavior means your behaviors. Therapy, of course, is therapy. And really what it's focused on for narcolepsy are the things you see up here, how well people are functioning, quality of life, those kind of things. Unfortunately, there's only one review paper. The Agudelo is the paper that talks about CBT for narcolepsy. There's no protocol right now. There is for insomnia, not just narcolepsy yet. We're not there. And what this review paper does is looks at a series of case studies of other things that people have done, just to find what are the techniques people are using, what are the things that we're focusing on, especially what are the things that have been helpful for people. A couple other things that we look at, there's just higher rates of comorbidities. There's been a talk on comorbidities already, but we're seeing that people who are dealing with these chronic conditions, they have more problems, which makes sense. You're dealing with a lot. There's a lot that's going on that's been dysfunctional in your life, and then sometimes we get depression and things. But that's not the only one. Whether we're looking at employment, with life, with families, with kids going to school, with how well you're doing with physical activity, there's all kinds of domains of quality of life that get impacted in tons of areas for intervention. Was that a hand raise? Or? Yes.
Did that study correlate your cognitive behavioral therapy with more hard evidence through functional MRI or a STAT scan? So these neurotransmitter levels are lowered from your CBT?
Unfortunately, no. Like I said, this is a really young area. The field's just started. I think that's a great idea for what they move next with. Part of the problem is that well, a psychotherapist, we don't see that many people with narcolepsy. It's still an underappreciated, underserved population. And so I think there just haven't been enough people to do larger scale studies, unfortunately.
Do you think narcolepsy psychologists first before they get fully diagnosed and then just never come back yet?
I would imagine people would get their sleep doctor would be the one diagnosing, and then is part of the treatment recommendations is, hey, you have a lot going on, and plus there's some skills that you're going to find out in a second that might be able to help you. And so we'd be a second stop, mostly because narcolepsy isn't a psychological condition. It's something that has effects. Okay, this is a busy slide, but this is the core components that the Agudelo paper really talked about. The behavioral components, which I'm going to speed through some of these because you've heard them already. There's cognitive components, how we modify things, and then education, really helping people understand their condition, what's going on. But I did hear a talk earlier, and I actually would like to add that to this, that it's not just being educated on narcolepsy, but also educating the people you're working with. as you all know, there's a lot of misconceptions about narcolepsy, and even amongst providers, unless they specialize in narcolepsy, a lot of people you work with probably don't have a great understanding, or they might, but it depends on where you are, what resources you have available. So all these are important pieces of it. And actually, they broke it down into, I guess it's 7, there's more like 10 different areas of intervention. And I'm going to show you a couple more models of this too. But these are the main ones that were found of here's what we've been trying with CBT. You can tell some of these are very they're very behavioral. Other of them are more cognitive. But there's a lot of different ways we can address this. We're going to go through all of these. But yes, they're done to address a whole slew of the different symptoms that you might experience with narcolepsy. Oh, sorry. Another way to look at it, because this is complex, especially amongst the people with narcolepsy, it isn't that everybody has the same symptoms or the same experience with it. There's no one-size-fits-all model, which I think also complicates this. What we do, or what we're trying to do, is think of different ways, different pathways almost, that, okay, here's the symptoms that we're aiming for. Here's how we might address it with you, or maybe we go down one path, then try another. And again, there's different answers, different ways we can treat this for different people. All right, and what I decided to do is break into 3 more helpful domains. This is the exact, excuse me, this is the exact same stuff from the last slide, but just really in domains of how we might treat it. And I'm going to start with the health behaviors again, because you've already gone through that, but then go to the relaxation, and then lastly, the cognitive piece, which is the part I enjoy the most. Sorry, you get it? Okay. Okay. So to start off, what I'm going to do throughout this is really talk about how some of the intervention we do works for both chronic pain and for narcolepsy, and then really trying to marry the two, that, hey, if you're learning skills for both or trying things for one, you can help yourself with the other. First being sleepiness. I know that all of you have heard probably in almost every talk you have something about how to schedule naps, or you've already came up with your own ways to do that. And really what we're trying to do with this is let yourself be your own scientist, to know when you're getting those daytime sleepiness attacks, and then proactively planning naps, really to help yourself get through the day more efficiently. With chronic pain, it's pretty similar. We want to reduce naps, have good sleep, but also put it at times that are going to be more helpful with your day, increase in functioning. Like I said, we're going to kind of move through these a little bit quicker. Diet, same thing. I didn't write these. I'm just the one that is putting them up. They are from the review. Because there's some things in here that are hard. I mean, it's talking about coffee and other things that we love and not always recommended. Yes?
Just to put the opinions.
Absolutely.
I've been seeing it 20 years, it's never come up before, and that is that you talk about differences from person to person.
Yes.
But is there data on, for each person, is that usually consistent that their napping sleepiness attacks are coming in a regularly scheduled way, or is that in itself, in an individual basis, individualistic in the same way that all of people, that sometimes sleep feels refreshing and sometimes it doesn't? It's a weird kind of non-uniform experience.
Yeah, I'd imagine the latter. I don't have narcolepsy, so it'd be hard for me to speak on it from a personal sense. But no, I'd imagine it's more individual, that for some people they have kind of standard, and other people, probably some days I feel tired, some days I don't. And it's really just finding the schedule. It's not a perfect science, I'd say. But for some people, it could be helpful for having that schedule. Eating's another thing, avoiding alcohol, doing other stuff that's just going to help you. Regular sleep, or excuse me, eating tips that you've probably heard before. Yes, back.
I'm just curious if this may not be because you're not a nutritionist, but what is the rationale for the breakfast 1-2 hours after waking?
I'm actually unsure. I think it's probably just with metabolism and waking. I really don't know the answer for that. It's.
Fine, I just thought I'd try.
I would ask around. One of your narcolepsy or diet specialists might know even better than me. But we do know with increased weight, we do have worse symptoms, both with chronic pain and with narcolepsy. So by eating healthy, by plan snacking, eating your good 3 meals a day, everything you heard since first grade about health, those things are going to help with symptoms. Exercise being another one. For narcolepsy, it's great, and these are actually the NIH recommendations that they have right now, just about being able to be active each day and how you plan it before when you go to sleep. Again, somewhat individualistic about who you are, what you're able to do. With chronic pain, we're up in the ante a little bit more. It's much more important. I'd say essential. I exclamate that because it's such a big part of getting the body moving again, getting that functioning back. When I was trained, it was do enough to make you sweat, but I'd say that might not even be the case. Do enough that lets you get up, because some people are pretty disabled by their chronic pain. It can be a huge impact on life where they're not able to get up and do a lot of things or get up and do enough to make themselves sweat. So maybe it's more of, well, can we get up? Can we do a little bit more in gradually increasing functioning? We typically recommend physical therapy for that, and having somebody help you with that, give you exercises, and really pacing it so you're not overdoing it. Overdoing it can cause a rebound pain, but gradually building what you can do so it's bigger and bigger and bigger, your functioning's bigger too. Yes?
I think I have two really horrendous chronic pain conditions, and I think the thing with the exercise is you're retraining your brain that when you do something it hurts and then it gets better, and you're kind of making that the association with the pain rather than just I'm hurting no matter what I'm doing.
Yeah.
It might be retraining just the perception of it.
Sure, it's part of it, and as part of what I do with therapy, that's part of it too. And really that kind of moves into the last one too, that this is a long-term solution. It's not that you're going to exercise today and you're good. That's not how it works. And it's not even that you're going to exercise today and tomorrow and this year and it's going to change. While daunting, one of the things we typically say is for some people it takes about as long as it developed to also get through it. I know, and you're like, that's been 20 years. But that doesn't stop the fact that we can get closer to functioning and get back to where we want to be. And that's really what a lot of my message is going to be, is that it's not something that has to stop you, much like narcolepsy either, that we're trying to increase that functioning. That's alluding to a later slide. All right, the fun stuff, relaxation. This is the stuff I really like. Relaxation is wonderful. If you missed it, there's a hypnosis talk right before this. If you missed it, it's going to be on the video, I think. I would definitely recommend watching it. It hits on the exact same things. It's great for reducing symptoms, and there's a link between symptoms and how your body's doing, really your body's stress response, which goes back to that central sensitization and really your nervous system. It was mentioned earlier, but in conditions like cancer, diabetes, it's not going to cure them, but it can really help out disease progress and how that process goes. So a wonderful skill to have, and with chronic pain, of course, that nervous system and even tension with muscles, if we're able to relax that, that also helps. Tension increases pain. So I will say the review article we have, I don't love it because they put a lot of different things in that they talk about in different ways, but really we're talking about the same thing. They use the word desensitization, and the way they talked about it was really to reduce cataplexy. I think they were also referring to some of the hallucinations between wake and sleep. And this is really kind of how it looked. I think in the last session somebody asked about a treatment protocol. This is about what it is. You're imagining the situation, and really what we're doing is building self-efficacy. You can see yourself going through this, starting with an easy one and getting to the bigger, scarier ones. And for some people, this might be, we're trying to work through when it happens, I'm going to have a cataplexy attack. How am I going to respond? How am I going to keep going and be able to get through the day? With other people, we're thinking, how do we reduce these from happening at all? How do we envision ourselves going through the day without an attack? This also could be called imagery. It's a little bit of hypnosis. There's different ways to package it and a little bit difference in how we talk about it with each one, but we're going for the same thing, is you getting through the day, you being able to feel like you can and really seeing yourself do it. With chronic pain, desensitization has a total different meaning, although we do the exact same things I just mentioned for it. With that, with allodynia, again, that's it hurts to touch. We touch it more. It's kind of a painful, yes, kids love hearing that one. We're gonna hurt you a little bit more. But what happens is as we're giving different signals to it, whether it be by temperature, cold, pressure, scraping it a little bit, we're resetting those nerve signals. So they're like, oh, this is what it's supposed to feel like. None of this is fun, by the way. It's difficult. It's hard. We're asking very difficult things, which makes it even more of a problem. But the visual desensitization imagery, again, we could put this in the box of hypnosis as well. And that's, okay, you can't use your foot right now. It hurts to put pressure against the ground. Well, how do we see yourself walking? And you've probably heard of mirror therapy. We do it a lot for post-amputation and other things. Even just seeing your other foot, but it looks like that foot, can make a huge difference. I'm not going to overload you with videos. There's a YouTube out there. You can probably find it. It's a guy with his hands out, and they move one hand and put a fake hand there with an arm kind of attached to him, and his hand's hidden, and they're brushing both of them until it feels about the same, and then the guy takes a hammer and just smashes the fake hand. The guy that it happened to, it hurts, and he's grabbing his hand in shock and terror. It never got hit. Again, just imagining that that's happening can have a huge impact on what we're perceiving and how it's going to us. Not again. Okay. Well, we'll do it the old-fashioned way. I hope this works. All right, there we go. All right, imagery and hypnosis. I'm going to speak of these together. They are separate things, but we're going to talk about them in the same way today. We already kind of described it in narcolepsy. Really, this is how do we visualize things happening differently, and how do we feel relaxed while they're happening. Some of the hallucinations you might face can be pretty terrifying, especially when you don't feel you have control over them. What part of this therapy would be is how do we start envisioning these happening well? You had somebody in the last one ask, well, my daughter has nightmares. Is it good that she goes back and tries to fix them? Absolutely. We want you to do that, not even to go back to sleep, but while you're awake. Practice those again. Practice it with a good ending. Practice it where you have superpowers. Practice it where there's something you can do to get through it. It can make an amazing difference. And what happens really is there's neural pathways for your dreams and really anything you do. And so when your brain gets to this track where it's going on that the nightmare, it starts to go back to that, oh, well, I've practiced this route many times, almost like water eroding soil. That's where our neural pathway goes too. So we're more likely to have that positive end to the dream or positive experience. Now, this isn't foolproof. It doesn't always work. You're still going to have some nightmares. You're still going to have some things that are upsetting. But it's how do we get you closer to feeling like you have control over it, that you can do something about it during the day, that this isn't something that's taking you, it's something that's part of you and you can take with you. With chronic pain, it's the same thing. We're really trying to calm the nervous system, but the same kind of skills. Instead of thinking about our pain and how bad it's going to impact us, we think about getting through the day. How do we get ourselves through the workday with this? Or even for some people, it's turning that channel on I'm at the beach, I'm somewhere nice, and this pain is actually not that bad. It's just the sun beating down on me, and that's not a bad thing at all. And really trying to convince your brain that this isn't too bad. There's a physiological change that happens with that too. So what we're doing isn't just, well, I heard the word mind over matter used a lot of times. It is, but it's more than that too. There's actual changes that can happen when we're using these skills, and those actually do have MRI data behind them. All right, muscle relaxation. This is actually my favorite one during the day. I'd guess most of you are probably already good about this and don't even know it. Now, with narcolepsy, we're using this to calm down some of the symptoms. Again, the more calm our body is, the more relaxed we are, the better we're feeling, the more we're in the present. Usually with any type of disease, condition, you name it, you're going to do a little bit better. With chronic pain, same thing. We want to calm down muscle tension. We want to calm down that response, especially that central nervous system response. But we'll actually do it together for a second. So first off, has anybody used progressive muscle relaxation or muscle relaxation? All right, I see a few hands. All right, well, you're out for a second. How about, has anybody ever used a stress ball? Okay, I saw you said yes. I'm going to point you out. Why'd you use a stress ball? Did it work? Yeah.
I don't know. It lacked avatar makes up for my jaw because I was clenching my jaw as I was.
Well, and the question that comes with that is why would a stress ball work for people? Why give them that as a token? No. And most of us don't. We just do it because it feels good. And then you might have had the experience too. I have really poor posture, so middle of the day, I'm at my desk and I'm like, oh goodness. Done that before? Yeah, we've done that. We do things to relax our muscles naturally. And part of what we're doing is we're creating tension and then we're releasing it. And really what that's doing is changing the baseline. You have tension right here, you raise it up a little bit, and then you drop it down even lower than it normally would. And that's what muscle relaxation, progressive muscle relaxation, be one of the skills for it. Let's practice it for a second, though. This will be one of the things I can give with you. We'll start with just doing hands, because those are easy, much like that stress ball. So what I'm going to have you do is put your hands in your lap, just in front of you, nothing crazy. So you already know how this one works. We're just going to squeeze them real tight. We're going to hold for about 5 seconds. 4, 3, 2, 1, and then you relax. Now when you're relaxing, this is the part I want you to focus on. Because what we're doing is really noticing the change in muscle tension. What's happening when you're tense, what's happening when you're relaxed. I usually want you to relax for about 30 seconds. During this, I also want you to notice what it feels. Is it warm? Is it loose? Is it jello? Is it heavy? Is it sinking down into you? Those are the words and experiences we want to focus on. But to really make this work, we want to do it twice. Much like you might warm up for a sport, we want to also warm up these muscles. You might not feel anything the first time. But we wait a little bit. And this time, especially if you're somebody who didn't feel a change, I want you to notice the split second from when you go tense to relax, what that experience is. So let's tense it one more time. So we're going to hold it tight. 5, 4, 3, 2, 1, and let it go. Pain for you, that's going to be tough. Caveat to this, if it causes more pain, causes any cramp, don't do it with other muscles. You can do this with any muscle in your body, but what I want you to do or be able to do when using this type of skill is really noticing what it is when it's tense, what it is when it's relaxed, and we're going to try to find that relaxed state throughout the day. That's what we want to do. And so the more you practice this, the more you become expert at it. That I know what my body feels like when it's tense. I know what it feels like when it's relaxed. I'm doing something right. Wait a second, I'm feeling a little tense. I need to relax. So we'll end that part. And again, this is something you can do with your toes, your thighs, your stomach, your shoulders, your back, your face, your nose, anything you want. Tense, relax. We're releasing muscles. We're making them feel a bit more loose. It helps out with how our body's doing overall. All right, my favorite part, cognitive behavioral therapy. This is what I do every day. Now, there's some big things, really, and I think this has actually been talked about before this weekend too. There's huge impacts on occupation, on life. Sometimes you just need somebody to help you through some of this stuff. Now, I know a lot of you are strong. That's an understatement. When you're dealing with chronic conditions, and even if it's not ones we're talking about in this, it can be very difficult. And you can look, these are about identical. We are trying to think about how do we support you best with what you're going through, however it's impacting you. And everybody's road and story is a little bit different. There's something else that's going on in each person's life, but really finding somebody that can help you with that. The realistic decisions, what I think about that is that for some people, narcolepsy or chronic pain takes them away from this career path. I've heard people this weekend talking about I was in med school but had to drop out. I was doing this job but had to change it. And it can have such an impact. What I'd want to do is, first, where do we put you though? How do you still find that fulfillment, that thing you care about? But how do we get you there to that road? And that if symptoms are stopping you, why is that? Is it stopping you because, hey, you really can't do this and we do have a limitation at some point? Or is it, I'm afraid that this is going to happen? And that's where we want to make the distinction. And when it's that fear of, I'm not able to, I don't think I can, that we can get you through that to the next step. Now, here's the other thing. And I'm not going to go through the whole cognitive behavioral therapy because there's a lot to it, and it's something that takes a little bit of time. I'd recommend working with a counselor, psychologist, somebody like that. But there's a lot of different things that come up with this. I think that's really where this goes, is that with no matter what your condition, whether it be pain, narcolepsy, a mixture of both, the thoughts make a huge impact. As you see, we have dysfunctional thoughts. Even if you don't have either of them, you're going to have dysfunctional thoughts from time to time, and those thoughts then become something that can affect us, and our symptoms can make those even worse. If you're having cataplexy attacks, then what's going to happen next? How am I going to get through this? Will I be safe? But then also that changes functioning. And for some people, it's not just what if, it's that, I don't even want to try. I avoid this situation. I stay away from that, and sometimes in ways that impair us even at greater levels. The goal of therapy, again, becomes how do we change this? How do we change some of those unhelpful thoughts? Some of it's through relaxation or really coming up with a plan that's specific to a person. But it could also be, how do we just think about things differently, and how do we get rid of some of that fear? And again, with chronic pain, that's very similar. What I talk about is the fear of pain, that we don't want to use the stuff that hurts. It hurts. I mean, it's natural. It's what you've been doing all your life. If your arm's broke, you don't use it. And when you have these types of chronic pain too, you don't want to use those either. But again, the goal is we have to use it especially after we've done the scans, we've done the $1 million workup, we know that this is a chronic pain or some pain that people can't even put a name to, which happens a lot. There's still this avoidance that we want to avoid. And then also this whole, I have an inability to do something. I have chronic pain, there's nothing I can do. I hear this all the time. Or I have narcolepsy, that's it. I've tried Provigil, it doesn't work, I don't have anything. Really changing that no, there are things you can do. Maybe it won't cure it, that's not what we're going for. I don't think anything I'm saying here cures narcolepsy. What we're talking about is how do I manage the symptoms? How do I do stuff that allows me to function the best way I can? And so really that's what we're going for. All right, so in sum, a lot of people have chronic pain. It's a very common thing. And then amongst narcolepsy, a lot of people have that. What you're experiencing, you're not alone in. There are things that can help. Again, not cure, but can help. Things that you can do to manage your symptoms, things you can do to help get through the day to really make your life bigger. And again, that's the last part. What I'm hoping you take away from this is that there's a lot of different skills that can be used for a lot of different things. For chronic pain, for narcolepsy symptoms. And the goal being that no matter where you're at today, making a move towards bigger functioning, making a move towards a better quality of life, doing more for yourself, for what you want to do, for that goal, that value you have. And just to let you know that there are things you can do, that you do have some control, and if you keep working at it, we do see good results. And again, hopefully that's what you take from this, that there's more functioning out there for you, and we can keep on moving forward a lot of different ways to get there. So thanks. Questions? Yes, in the green.
So I'm like the poster child for this.
Oh.
I've had narcolepsy since I was a child. I have fibro. I have chronic hemicrania,
Mm-hmm.
which is an 8-year perpetual migraine that does not abate ever. And I have done all of these things. My neurologist sent me to really intense, what do you call it, the 8-week session of modified perception modification stuff.
Yeah, one of the intensive programs, yeah.
Guided meditation.
Okay.
That's it. And that was through Jefferson Hospital. And then I started realizing that I can dissociate from this. It can just be. And if I don't let myself have an emotional reaction to it, then it exists on such a different amount. And you see how productive I am. You know what I'm doing. For the body I have, I shouldn't be that productive. And it's all the CBT stuff. And so recently, CBTN is not available yet. We're working on it. The next best thing, I was about to have a major shame thing. My mother-in-law moved in with us. My entire life, my sleep schedule has just been whatever the hell it was. But I could not imagine the shame of sleeping until noon with this woman in my house. So I was highly motivated, but my sleep doctor sent me to CBTI. And I'm just astounded. Yeah, well, is the insomnia. Fiber reader training, narcolepsy protocols, and that, but insomnia is. And a whole lot of that is building up intentionality. But we talk about sleep hygiene, and I'm like a maniac on sleep hygiene, doing it, but it turns out I was adding layers to my sleep hygiene because it worked for me 27 years ago, but now it's just fueling me. And so I am actually at the point for the first time in my life, I'm waking up without an alarm. I mean, I've never had it like this. And then she says to me, okay, now we're going to work on tailing down your sleep meds. And I'm like, oh, no. I'm like, no, I get something on my brain. I'm taking a third of the sleep medication I had my whole life.
Which is wonderful.
And I was a psych major, so I've seen the data of how brain chemicals change. Oh, and the last part of that is, so now I'm in menopause, I don't have hot flashes because I learned to disassociate these things that happen from my absolute reaction to it. And so it's like, oh, yeah, that could happen, but it's not.
Yeah, and I love that. And it can definitely play a part. And some of what you're talking about is a mixture of this CBT, some of the self-hypnosis, and other things. I'm glad you're using those skills. I just saw a thing that I have about 5 minutes. Who else has questions? You had a question.
So CBT is big on retraining the brain to react in different ways.
Correct.
And mitigate these other conditions have used benefit from CBT, but also benefit from more kind of mechanical stimulus, like transcranial magnetic stimulus, TCDS, direct current stimulus. Do you know of anybody looking into that, or researching, or funding anything like that to look at magnetic stimulus to
I know there's some going on, also still pretty new. I know in the physical therapy realm especially, they're using things, and it's called a dolphin. I don't know exactly what the actual name for it is, but it's the same kind of magnetic stimulation. I don't think there's any big randomized controlled trials or anything out for that yet, though. But it is something that can be used and helpful.
Is there a website or any direction that you can send us to find a practitioner that does the CBT in our area?
So the question was, how do we find somebody? That's the toughest part, because it's really going to be dependent on a lot of things, including insurance and what they're providing. Usually on, if you just searched psychologist CBT in your city, did you say Chicago, I'm guessing, by the they have them there for sure. But then it would just be who is with your insurance. Sometimes you can call your insurance and ask, they'll give you a list. Other times you can go and there'll be sites like Psychology Today or other sites that'll come up on Google, and usually it'll list what they do, what types of therapies they do, and what insurances they cover. So usually a good Google search will find that for you, but insurance can also help guide you. Yep.
And then if they're giving you the CBT in relationship to your chronic pain or your narcolepsy or if you have insomnia, that's a medical condition. That's usually if your insurance plan doesn't like to cover psychological services, this is now a medical service.
Yeah.
It's more likely to be covered.
Yeah, we'll charge as a health behavior code and still get reimbursed. So we'll do that. It can be a long time, unfortunately, and sometimes psychologists get very booked depending on where you're at. Other questions? Yes?
I have a side question.
Sure.
On acute pain.
Yes.
I'm dealing with some bursitis and hip pain and stuff, and I was using CBD oil. Are you familiar with how that might react with narcolepsy? Because people use it for sleep, which I wasn't wanting it for.
You threw, yeah. You threw a curveball at me. Yes. Unfortunately, I do not know enough about the CBD on narcolepsy. I can tell you for the pain, there's actually a review paper not too long ago that looked at it. It was a 54-page paper, just looked at everything. Right now, there's no evidence that CBD helps pain. Now, there's probably somebody in here who's taken CBD and it helped their pain. So that meaning that more than placebo, more in like a large group, it's all individualized. So I'm not sure. It'd definitely be something to talk to your doctor about. If you find Dr. Ortiz in the back standing up, he could probably answer some of those questions afterwards too about how it interacts with narcolepsy. But as for pain, yeah, as he leaves. But for pain, there's not enough evidence for it, and that's because CBD isn't regulated, and we never know you don't know what you're getting. So, okay, clap, 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 we're done. Thank you. If you have other questions, I'll be around. I wasn't trying to ignore your sign.